Just.
So we actually changed the title a little bit because when I was initially assigned to that topic, I had to text Dr. McKinsey and say, I don't know how to do that. So we've adjusted the title to endovascular treatment of thoracic aneurysms using the Cook Thoracic Endograft. Good. Yeah, I have no disclosures. When we talked about thoracic endografting, the biggest discussion for the longest time was always about profile. The devices that we were putting in were large profile devices in patients who often have compromised access vessels and iliac disease. And putting in devices that were above 22 French was often very, very compromising and difficult to do. So Cook has made some advancements in their endografting. They've gone from their traditional TX2s to the alpha thoracic low profile device. And these are the changes that they made. They went from stainless steel stents to nitinol stents, which they can compress a little bit better. They went from the standard polyester to a thinner, more tightly woven polyester. And went from the covered proximal stent to a bare rounded proximal stent as well. And by doing that, they were able to reduce the French size to 16 to 20 French for almost all of their devices, which is really fantastic. They were able to do that while maintaining still a pretty wide graft diameter. It used to be, when it initially released, their IFU was 18 millimeters to 46. We'll discuss about why they kind of changed that. And this now, I believe, is the second widest range, with the Gore C-Tag being the only one that has a slightly wider range than the alpha. The changing to the nitinol made them a little bit more with improved MR compatibility, allowing you to get imaging for these patients without any kind of concern about the stainless steel moving at all. Dr. Torsello, one of our co-directors for this session, was the author for this when they looked at the durability of the low-profile stent graft. Oftentimes, when you go to a lower profile stent, you worry that you've compromised the integrity of that stent graft, and you don't know whether or not it's going to last for a long time. So Dr. Torsello's group looked at these patients from August 2010 to October 2015, 70 consecutive patients with a mean follow-up of 22.3%, and they saw 87.1% clinical success. 61 patients were able to undergo good technical outcome with the device. Out of the 9 patients who didn't, 6 of them actually were treated outside the IFU with a short landing zone less than 2 centimeters and had a narrow Leicester curve. Their 30-day mortality results were pretty good. They had 5 out of 70 that died, and they specify why the patients died. One of them was a 12-centimeter aneurysm, a thoracic aneurysm that caused significant compression and dysphagia. That patient actually succumbed to CHF exacerbation and died from that. 1 septic shock, 1 MI, 1 pneumonia, and 1 unknown. When they looked at their durability outcomes out to 1 month, 3 had a type 1A endoleak, 2 with a type 1B endoleak, 1 aneurysm sac enlargement, and 1 case of migration. And all-cause mortality at 76 months, and when they looked at their data, was 17.1%. So their conclusion was that Zenith Alpha was able to maintain favorable results in a longer time frame with low incidence of sac growth and migration. Just to kind of change gears a little bit, because of the wide range of sizes and the lower profile, the Zenith Alpha in particular was attractive to use in trauma sessions when you have to put in potentially smaller endografts for these patients. And Dr. Starnes from University of Washington kind of led this trial when they looked at the use of Zenith Alpha for blunt thoracic aortic injury. And from January 2013 to May 2014, they had 50 patients who had blunt traumatic aortic injury across 17 sites, and they published their 30-day results. The overall adverse event rate was 16%, with 2% all-cause death, which I think is pretty remarkable. You're talking about patients who have blunt traumatic aortic injury that are coming in, and you have a 2% kind of death risk for that, which is pretty remarkable. When they looked at their 30-day core laboratory imaging statistics, 100% of these stent grafts were noted to be patent. 76% of them actually went on to full aortic healing with resolution of the area of injury. And they had 2.4% type 2 endoleaks and 4.9% unknown endoleaks. Out of the device integrity, there was noted to be some compression, 2.5% of them, but still, once again, they note 100% patency at 30 days for these grafts. So the overall conclusion was that this is a very successful device to use in blunt traumatic aortic injury, and you can use it in all cases of trauma. But last year, in August of 2017, Cook started a voluntary recall for some of their sizes, indicating that some of the grafts had demonstrated, when they were used in trauma, that inside the graft, some of them demonstrated thrombus within the graft, and particularly these were the ones that potentially were smaller in size. So Cook initiated the voluntary recall of the thoracic alpha devices from 18 to 22, and this includes the 26 to 22 taper device, which are no longer available on the market, leaving 24 to 42 being the range for Cook alpha now. It's probably okay. When you look at Dr. Starnes' chart in his paper, only 8% of them, 8% of the devices that were replaced were within those sizes. You know, majority of the other ones were all within IFU still. One of the things to talk about with alpha, it's my go-to graft for many cases because of the low profile and ease and accurate deployment, but there are some things I do wish were a little bit better. Oftentimes during this session we've been talking about when there's aortic arch aneurysms, dissections that go proximally, that we need to be able to sometimes deliver these grafts further into the aorta, not the traditional zone 3 and zone 4s that we like to do for TEVAR in particular. If there's arch involvement, you know, we work with our cardiothoracic surgeons in order to do some sort of hybrid procedure where they get aortic root replacement or a debranching of the graft. After this is done, we need grafts that's able to be delivered actually up to that zone 0 or zone 1 of the aorta safely. And this is probably the one area where I wish the Cook was a little bit better. And the reason is this: when a lot of the times when these hybrid grafts are coming off, they're fairly close to the aortic valve, and you can see that the length that you have is not very long. And in order for you to be able to deliver these devices very close to it, you need something that has a shorter nose cone. The Cook device, while it tracks extremely well, the nose cone is the longest one on the market. It's a 7-centimeter nose cone. So in order to do this, a lot of the times you either have to coil the nose cone against the aortic valve or put your wire through the aortic valve, kind of like they do in the TAVR procedures, and deliver the nose cone almost through the aortic valve. The other nose cones on the market are a little bit shorter. So the Medtronic is around 4.5 to 5, as is the Bolton Relay. The shortest one that they have on the market is the Gore C-TAG, which is only a 3-centimeter nose cone. So this kind of has been my graft of choice when I go all the way up to zone 0 for a lot of the cases. So in conclusion, Cook Alpha has successfully lowered their profile without compromising durability, at least in the short-term period with the follow-ups. Smaller sizes have been removed off the market for concerns of intragraft thrombus. Shorter nose cone may help. That's my own personal wish that hopefully the engineers can kind of do and still not lose any of the trackability that they have, which might be a little bit tough. But thank you very much for your attention.